Many of us carry experiences of individual, interpersonal, and collective trauma. Trauma takes many forms and impacts how we think, feel, and behave. Sometimes we wear our trauma on our sleeve, sometimes we keep it completely hidden. When we interact with a healthcare service, either as a patient or a member of staff, past experiences of trauma may come into play. This is Sophie. She grew up in the care system and is terrified that her children will be taken away from her. After putting it off several times, she contacts her GP surgery for help with her mental health. She is called by a GP who asks if she's coping at home. She says, of course, and doesn't dare share that she sometimes thinks of hurting herself. Sophie is asked to attend a face-to-face appointment. It is with a doctor she's not met before. He asks questions that she wasn't expecting, so she tells the doctor what she thinks they want to hear so that she can leave as soon as possible. This is Saida. She is a GP and a single mother who has left a 10-year abusive relationship. She has never disclosed her experience of domestic abuse. During her 12-hour working day, Saida has many patients to see, stories to hear, and problems to try to solve. She feels overwhelmed and exhausted. Both Sophie and Saida are at risk of being re-traumatized as they interact with the healthcare system. The environment, clinical practices, and methods of communication can all influence this. A trauma-informed approach involves transforming how a healthcare organisation operates to help prevent re-traumatization and to improve experiences and outcomes for all. So what do we know about the effectiveness of trauma-informed healthcare? Our TapCare study reviewed the evidence by analysing research reports and policy documents and interviewing healthcare professionals. We found that there were different components to successfully implementing a trauma-informed approach. Healthcare organisations tailored these components to suit their needs, abilities, and preferences. There was evidence that this approach could create a safe and supportive environment and improve experiences and outcomes for some patients and staff. We also found that the implementation of trauma-informed approaches was patchy across the UK, and that it was driven by individual trauma leads rather than by organisation or system-wide policies. If we are to successfully implement a trauma-informed approach to healthcare in the UK, our study suggests that we need guidance and a strategy from government and the NHS, and an explicit commitment to implementing trauma-informed approaches. UK-wide spaces where trauma-informed working groups and people with lived experience can share resources and learning. And evaluation of all trauma-informed initiatives so we can strengthen the UK evidence base and inform health policy and practice. There are lots of ways you can help to support the development and implementation of trauma-informed care in the UK. To find out more about our research, please visit bristol.ac.uk/TapCare study.